As many of you know, in health coaching and beyond, we alternate conversations between the two of us, chewing over hot topics, latest news and emerging ideas, but also bringing you conversations with thought leaders and people we admire in the field of health coaching and beyond. This week, I'm joined by two true experts in the field of patient activation. In fact, I can't really think of anyone else I admire more for the development and championing of this approach. Many of you will know that at Peak Health Coaching, we consider patient activation to be a key concept. It's a concept that emerged in academia and has stood the test of full application in real-world practice over the last 40 years, driven and shaped by people like Alf and Jag. Patient activation is the skills, knowledge and confidence that people have to self-manage their own health. It builds on the principles of agency, autonomy and self-efficacy. We consider activation at the individual, group and system level. We get to some really pragmatic and practical ways to embed activation in our current ways of working. As always, we hope this conversation supports your thinking and how important it is to support people to grow their skills, knowledge and confidence to self-manage. Right. Hello, folks. I'm absolutely delighted to be joined today by the two people I consider the most contemporary experts in the field of patient activation. So I'm delighted to be joined by Professor Alf Collins, who I've known for many years for his leadership roles for NHS England in the chronic pain field and many, many other areas. And he will introduce himself in a second. And then Jag Mundra, again, a friend and a colleague who has been really dynamic and innovative in this area of patient activation and how we turn things from theory into real life. So perhaps Alf and Jag, Alf, you start. You could more formally introduce yourself for our audience.
Ollie, it's great to be here. It's great to be here with friends and colleagues, people that I really like and respect. I'm a doctor. I worked in a pain clinic for many, many years, which we moved into the community, so a community pain management service. Alongside that, I've been a communication skills trainer for 40 odd years and got interested in the idea of activation over 20 years ago now. And I've done a lot of work in that space with various organisations like the Health Foundation and NHS England. So, Ollie, it's lovely to be here.
Brilliant. And of course, you were the clinical director for personalised care for NHS England for many years, weren't you?
I was there full time from 2016 to 2023, and activation was part of my portfolio.
Brilliant. And we'll come to all the ways you've brought it in across your career, Alf, in a minute. Thank you. But Jag, perhaps you could introduce yourself to the audience as well.
Yeah, no worries, Ollie. And thank you. It's such an honour to be here with you both. And thanks for inviting me. So my name's Jag Mundra, and I work for an organisation called the NAPC, the National Association of Primary Care, and also the National Academy of Social Prescribing as well. And most of my work is kind of involved in trying to measure the benefits of prevention or preventative care, but also try to find ways to nudge people or increase patient activation and improve population health. So I'm kind of involved in both sides, but largely the measurement and the data side of things.
Brilliant. Thanks, Jag. So many people that have heard us talk will know that at Peak Health Coaching, we're really wedded to activation and patient activation as a concept. And we define that as people's skills, knowledge and confidence to look after themselves or engage in self-care. And tailoring our approach to that seems to be a really good strategy. But Alf, perhaps I could come to you and just sort of, visit where did it all start and where did this concept of patient activation come from?
So I think we all know what you've just said, Ollie. Some of us are better at looking after ourselves than others. I mean, it's just a common knowledge piece. And that's the case whether we have a long-term condition or not. Some of us find it a challenge to manage our long-term conditions or life with our long-term conditions. Some of us find it less challenging. We've known that there's this concept agency, which is to do with our skills, knowledge, and confidence to manage in any given situation. Actually, agency is that actually I'm in this situation now. It could be in work, it could be in sport, it could be in health, and I know how to work my way through this. So people of high agency do tend to produce better performance, better outcomes. So that concept's been around for 50, 60 years. It came out of the University of Stanford, and there's a professor called Albert Bandura who did a lot of work in this field over 5, 6 decades. in his team, there were two people, one called Kate Lorig, who was the person who put in place the Expert Patients Programme, which I was part of many years ago. And there's another person called Judy Hibbard. And Judy and Kate started to think about how can we apply this concept of agency to health. And they started figuring this idea that it's called self-efficacy. To what degree am I confident? To what degree do I have the skills and the knowledge to manage life with my health condition? Judy started to think, actually, is there a generic way of capturing people's agency when it comes to their health and well-being? And develop this idea of activation. It's a generic, health-specific confidence, skills, knowledge, scale. Really well validated. It's been around for 23, 24 years. We brought it into the NHS in a program I worked on called Co-Creating Health for the Health Foundation 22 years ago. And actually we used the then 22-item scale. There was a wonderful survey by Angela Coulter of many thousands of people living with long-term conditions, looking at their levels of activation and demonstrating 21 years ago now that there are 4 levels of activation and about a quarter of the population are at low levels of activation, and about 4 in 10, as we all know, are at moderate to low levels of activation.
Yeah, brilliant. So, and this concept of agency, I think, is so important across healthcare and all segments, like you say. So, and this validated questionnaire. So it started with 22 questions. It's got down to 10 now, isn't it? I think a lot of us use the 10 question one, don't we?
Yeah, it started at 22, went down to 13, went down to 10. Judy tried 6, the 6-item measure. Yeah, they're academics. You know, they like stuff that they can demonstrate in trials. Fantastic work that they're doing. They're not, I'll just say this in the kindest possible way, that they're not necessarily implementers at scale. So, you know, we do need a much more readily available, smaller instrument than a 22 or a 13 or a 10-item instrument to actually take these concepts to scale. And I know Jaz's going to talk more about this in the next few minutes.
Let's bring you in, Jag. So Judy did a fantastic job from an academic point of view, didn't she? A proving case, getting this all validated. But Jag, you're an expert in pragmatism and making things work in the real world. So you've taken the concept on, you developed a single question measure to use pragmatically. Tell us a little bit about how you've built on the ideas of activation into a sort of pragmatic approach.
Yeah, surely. And so I guess when I've been rooting around in projects trying to figure out whether they're working or not, you're generally trying to find a measure or something that will tell you whether it's had an impact or hasn't had an impact. So that's my kind of introduction into activation in the first place. And when I stumbled across it, I was just so ridiculously excited to find this concept, because for me, the logic model is, especially when it comes to prevention, but for most things, firstly, people use a thing, then their behavior changes, then their health improves, then their demand reduces. So I'm looking for a behavior change metric that will predict future health and demand reduction. So stumbled across activation. I thought, oh my God, this is amazing. Why aren't we kind of why aren't we doing this everywhere? I was almost like, I find it quite funny. I don't know what the question is, but I know the answer is activation. It just made sense to me as a person as well, as an individual and also as a population. So then I came across the 14 question tool. Yeah. And I think it was at the point where the license was just about running out. And as part of a piece of work I was doing for NAPC, we were working in Calderdale, trying to measure different interventions and preventative care kind of stuff, the forerunner to integrated neighbourhood teams that we're seeing right now. And we thought, right, okay, let's try to implement a behaviour change metric that's going to tell us everything we need to know so we can learn quicker. And what we found is that none of the social prescribers we were working with wanted to use the full tool. Yeah. And we tried a different set of things, and they were really resistant to doing it. So we thought, let's just scrap it and instead ask them, with no agenda whatsoever, what question would they feel comfortable asking, and would patients feel comfortable answering just on their own terms? So kind of removing all the academic stuff. And they came up with something very similar to activation on their own, but it just was asked with fewer questions. And that was ultimately... we iterate the questions a little bit, but it's how good are you taking care of your health, or rate your health on a 4-point scale. It was funny enough, a GP in Oxford who gave me the idea. He said, the best depression questionnaire I've ever used, Jag, is just asking patients if they're depressed. So we thought, let's just try this out. It probably wouldn't reach an academic standard of validation, but it might just be good enough as a precursor to full tools.
Yeah.
So, and we did a search for any PROM or PREM. That's a patient-reported outcome in Calderdale before we started, and we found that about 0.02% of patients had anything recorded. That's any type of measure: Warwick Edinburgh, ONS4, activation, and
0.02%. So a fifth of a percent.
nobody.
Yeah, pretty
Basically
much
nobody.
nobody. Yeah.
Pretty much nobody. And within about 6 months, we had 1 in 2 patients receiving social prescribing capturing. So it was from 0 to about 50%.
Wow.
So they really took to the tool. And in their own words, they found it useful across 3 domains. They found it useful as a tool, so something they wanted to ask and answer because it helped them deliver better care, better preventative care. And it was useful as a nudge and a prompt. It was useful as a triage tool, which is its intended purpose. And thirdly, it was useful as a measure. So it helped them with QI and evidencing benefit. So we solved firstly the uptake problem. Then we looked at the data from the activation scores to just check. I'm like, oh my God, is this actually going to look right? Like I've said, 25, 25, 25%. And it was good enough. There was a nice bell-shaped distribution. So at least not everyone understands and answering the question normally. They're not all just saying I'm activated or not activated. And then so the distribution was good. So check uptake, check distribution. And then the third step, and there's 2 more steps, is that we then started to look at the correlation behind activation and things we care about, like GP contacts, hospital contacts, health, medicines. And it was positively correlated to, or negatively correlated to, all of those things that mattered. So higher activation, lower meds, higher activation, lower GP contacts. And that's in the literature as well. But the single question was doing the same kind of work. There was a little bit of difference with activation and BMI. But we think that was probably a health literacy issue. And then as part of that analysis...
They don't entirely match, do they? Health activation,
No.
health literacy, slightly different things, aren't they? Yeah.
They are. And what we found was that higher activation was associated with people's self-reported diet being better, but their BMI also rose. So we think that that's probably a health... we don't all know what that a good diet is. Yeah. So then the final thing to mention is that we're at the state we did something called a multiple regression, which basically controls for age, clinical complexity, mental health and social need, and then says, does activation explain GP contacts, or does it tell you something about future GP contacts once you control for those things? And it did. And in fact, out of all the things we tested that talk about future healthcare utilization, patient activation could be the strongest modifiable thing we've got to affect it. So we're marrying together a person outcome with a clinical outcome that's well controlled. In simple terms, we've done the stats to try to get as causal as we can, but it isn't causal yet. So that's the final step we're going to test now, is whether raising somebody's activation actually then lowers their GP demand. Because at the moment we've gone as far as we can with the numbers. So that's a bit of a kind of a history of how we've arrived at the single question.
Brilliant. And just to recap then, so the current wording in that is just literally asking people, how good are you at taking care of your own health? And there's 4 responses, I understand it, which is not very, okay, good, or excellent. And actually just asking that very simple question, that format with those 4 answers, is really enabling for a system, like you say, to sort of respond in a very different way.
That's right, Ollie. But I think the emphasis here is that it's not a validated measurement tool. That's quite distant. It's a tool that people should own and alter in the way that feels right. Because the first step is ask it and answer it. And if you feel that person you're talking to doesn't understand the question, or you arrive at that answer together, that's all fine. It doesn't have to be a perfect measure. That's not really what it is. It's just giving you an indication of what might be happening. And so we're not trying to go up against validated tools. They still remain, and they're extremely valuable. This is something that can start a conversation where otherwise there wouldn't be one.
Yeah, I love that. I love that sort of pragmatism there, and the sort of difference between, yeah, sure, really robust, validated measures are really good, and perhaps we could argue, as we did, Alf, didn't we, with NHS England, that we should be investing in these and prioritising these, but sometimes they're difficult to put in their full format, and patients and staff don't like it. So some more pragmatic, kind of easy use tools, perhaps as an entry starter of a conversation, is good to have as well in the system.
Can I come in on
Yeah,
that, Ollie?
do
Because
that.
you know, I started using the 22 item PAM and then the
Yeah,
13 item PAM 21 years ago now.
yeah,
And we ran a program called Co-Creating Health. Actually, one of the sites was Calderdale. We had 8 sites where we were teaching people what we now call health coaching. And we
yeah,
were teaching people to deploy questions like, how good are you at managing your health? How confident are you at managing your health on a daily basis? Um, and nevertheless, we were using the 22 item tool, and that people didn't like it. I mean, even
yeah,
then, 21 years ago, they were deploying the questions that now Jag has really made this massive leap forward. But they were then also, alongside that, using this really, frankly, cumbersome tool. And that was the major blocker to widespread adoption of these ways of working, was the fact that the tool was too long. So
yes.
I just want to pay tribute to your work, Jag. This is certainly in 20 years of the patient activation measure work. I think it's the biggest leap forward we've had. So thank you.
Yeah, it's
And
certainly
no problem, Alf.
certainly something we use in our practice. We use it now in the pain clinic I work in.
Yeah.
We use it in our social prescribing service. Yeah, and it is that difference in real life, isn't it? Between, you want the robust research, and it's fantastic to have had the work that Judy Hibbard led to kind of prove concept, but actually you need to make it doable and pragmatic in real life. I think that's the winning formula, isn't it?
Yeah. Yeah.
So we've talked ourselves, haven't we, the three of us, even in writing to advise NHS England around how you could use activation in different domains. So you can think about it at a sort of personal level. You can also think about how it affects group dynamics and the behaviour of clinicians and teams, and even at a community level. I don't know, Alf, if you want to come in on that, around how we can use this concept of activation in different domains in healthcare.
Yeah, so there is something, isn't there, about the fact that, healthcare is a complex system sitting within this even more complex system called the world.
Yeah,
And
very
we
complicated.
Yeah.
and we all have conversations with each other on a daily basis about our health. But kind of homing in on the healthcare system, we've known for many, many years, if you want to bring about a shift in the conversations that people have, the shift has got to happen in individual patients. I'm going to call them patients here in terms of people interacting with the NHS. There's got to be a shift in the way clinicians think and do things. And there's also got to be a shift at the system level, the health system level. And of course, the health system sits within this wider thing called community. For those of people who want to think more about this, there's something called the Wagner model. And the Wagner model, again, was brought in over 20 years ago. And it graphically describes exactly what I've tried in a kind of fairly clumsy way to describe there. So what we'd like to see is activated patients, people. We'd like to see activated clinicians working in an activated system within this hinterland of an activated community. That's
Yeah.
nirvana, isn't it? That's nirvana.
Yes, it is. And I have to say that, not because you're here, but I was, really grateful for the work you led with NHS England and around introducing person-centred care roles. So I know we both teach health coaching. We have a vested interest in there to a degree, but we've seen how bringing in skill sets like health coaching and roles like health coaches and social prescribing link workers to help kind of build agency across social sectors, activation across social areas, and care coordinators that help the most complicated people to regain control and agency.
Yeah.
We saw a real effort to try and drive that, didn't we? And I feel like we made a lot of progress with that.
Yes.
And I know, Jag, a lot of your research in Calderdale, where you've used the single question PAM and other markers around that, has shone a light on the benefit of these perhaps slightly periphery areas in health and social care being the ones that have real impact in building activation and the lead-on consequences of that.
Yeah, that's right, Ollie, and it's almost the reason why I'm here in a way, because when you start measuring things, you inevitably look at the results and you think, oh my God, so I spent 20 years measuring this and all of this stuff is really not making very much impact at all. But then I've come across health coaching. I think it was the Symphony data set. And I just looked at the ROI and the benefits, and of course they've got this activation measure alongside what they're doing. I mean, when you talk to health coaches, you feel really sane because they're talking about the basics of what makes sense to me as well. Then I saw the impact they're making on healthcare utilization, on activation, and I was sold, and I've been kind of pulled in that preventive care direction since then. But yeah, so I think, I've got to say, just a kind of big thank you to you both from that perspective for pioneering that work. I think now is almost an equally exciting stage, which kind of is about kind of scaling it. But I think the concept and the culture, I don't think we're starting from nothing now. I think it's there not just amongst health coaches and social prescribers and the other ALS roles, but I think it's there present in most people's minds because I think we've run out of road in terms of making change at the clinical end. We've almost got nowhere left to look other than those tiers that Alf described in activation at all of those levels. Yeah.
Yeah, thanks, Jag. And I know you've got some ideas about practical approaches at a neighbourhood level, but maybe, Alf, I'll just come back to you around, the personalised care program that you led for 7 years and the progress around these new roles. When you think about the progress that was made and what worked and what didn't, what when you look back on that now, what's your thoughts on it?
Yeah, it's interesting, isn't it? So I was there when, actually, it's interesting you talk about Symphony, Jag. I was working with the commissioning team in Somerset when the Symphony program kicked off, and I was watching what was going on with Symphony and thinking, my goodness, this is making a real difference. Alongside that, in Somerset, we had the Froome team who are doing a lot of work around social prescribing, and again using the activation measure and demonstrating massive shifts. It's written up in the BJGP a few years ago that social prescribing leads to improvements in activation, leading to reductions in unscheduled admissions and GP appointments. I kind of got all that experience and understanding and knowledge, and the idea was in NHS England we just flood the system with as many of these what are called personalised care roles. I don't like the phrase, actually. I think we should all be working towards a personalised care agenda, but they're broadly called the personalised care roles. Yeah, if we flood the system with them and support the system to support them in their role, to be clear about what their role is, to be clear that that they're not a dumping ground, or I can't think what to do with Mrs. Jones, or why don't I get them to see a social prescribing link worker? So at the centre, what you don't want to do is at all dictate what should be done, but provide some kind of guidance and direction and support. I think we did an okay job on balance. And I'm grateful for lots and lots of people, Jag included. There's lots of work coming out of Oxford now demonstrating, particularly for social prescribing, that it really makes a difference, particularly for people in our more deprived communities. So, looking back, frankly, we didn't really know as much about what we were doing as perhaps we ought to at the time. But it seems to me that the system itself is taking this by the scruff of its neck, personalised care, the concept of activation, and doing great work, thanks to the likes of you and Jag. Again, thank you.
It's tough, isn't it? It is tough, and these things go in cycles, don't they? And I know from a policy point of view, there's limited levers you can do, isn't there? You can suggest these roles should be there. You could provide some funding, but it takes time for the mindset to bed in, doesn't it? That this has value and how it fits alongside what people have been doing and got used to in their professions and in their systems.
And I was always cognizant of the health trainers, what happened to the health trainers. For those of you who don't know, health trainers were brought in by the Deputy Chief Medical Officer, Fiona Adshead, in the early 2000s to work to support behaviour change in our most deprived communities. And they did great work. But the lesson there was that they weren't really supported broadly. They weren't really supported locally, and their work began to kind of wither on the vine. And I really didn't want that to happen with health coaches, social prescribing link workers, care coordinators. And I don't think it has. I think they've got a clear, defined place now.
Yeah, that's great. That's a great legacy from that work. And we're in a sort of regroup phase almost, aren't we now? We're moving from primary care networks to neighbourhoods and thinking further again about how we can integrate across health social and self-care. And Jag, you when we wrote that paper together, and which we will link to actually, you talked about sort of 4 areas that we identify, we intervene, we integrate, and then we measure impact. Do you want to talk a little bit to that? Because I know that's some sort of pragmatic thinking from you again.
Yeah, sure. Yeah, surely. So I guess maybe I'll frame it this time in terms of, I guess at an operational tactical level, why aren't we a prevention first system already? And so I'll just start there because
Yeah.
I think it maps onto the same kinds of things. Maybe not quite as many, but I think, and this isn't an exhaustive list, but it's just a set of kind of tactical things that are addressable that I think contribute in a complex system to the outcomes we see at the other side. I think number one is that we don't have a systematic way of identifying the most impactable people. They're hidden to us. And when we reach them too late or not at all. So we need a tool, we need a way of doing that. And the second thing is that we deliver a lot of the work, both clinical and preventative, in a one-to-one way of doing things because we've just learned it from the NHS. So, so that one-to-one prevention dominates, whereas one-to-many models remain marginal. And one-to-one prevention is good. But when it comes to taking away money from an acute, it's got to be really, really good to take a chunk of money. It's got to be consistent. And number 3, we don't have a cheap, effective way to measure impact in a cost-benefit comparable way. Because even if we can prove something works, we need to continuously prove that it works for the acute to move cash because they need to performance manage the thing that they're looking at in the same way they performance manage the things that are under an umbrella. So it's about identification, intervention, and impact. So that brings me on to the kind of the hope here, I think, is if we can start to look at alongside one-to-one work, one-to-many work that can help activate larger numbers of people, we can stand a chance of shifting the whole of a population's destiny or their health. Because at the moment, we know that with a health coach doing wonderful work, their caseload is only going to be a small fraction of the total population. So it can't change the big number that somebody will pay attention to. And yes, they can activate the wider clinical team, but they don't have the structure to start to systematically activate everyone because it's a threshold-based business, isn't it? So people above a certain threshold. So the exam question is, is there some way we can offer something to everyone to help activate them and remove barriers in an environment of low to no resource? And I just want to give 2 examples.
That's the exam question. Sounds like you might have an exam answer as well, Jack.
Well, the two things that give me a huge amount of hope, or the 2 mechanisms, or the 2 kind of, I don't know, it's a little bit like a free energy in a way that we've just not tapped into. And the one is nudge, and one is the power of the groups. There's a piece of work done by Oxford that looked at brief interventions done by GPs to talk about weight loss. And they found that when a GP talks to a patient about weight loss for 30 seconds and refers them, and they take up that referral, they lose 2.5 kilos. It's great, So the brief conversation works. But the most interesting thing about that is patients who received a brief conversation but didn't get referred and didn't take it, they didn't get referred, they lost 1 kilo. So the conversation generated 1 kilo, 30 seconds, and then the whole intervention generated 2.5 kilos. And I thought, oh my God, because a 30-second conversation isn't a difficult thing to have. Well, it can be in a primary care setting, but it highlights how powerful nudge could be for patients below a certain threshold, not patients who need help. And then similarly with group-based work, when we've got health coaches working in large virtual groups. So think Thursday evening, 6:30, Netflix time. So lots of, not the main intervention, but like a precursor intervention. So I'm not saying we deliver everything digitally. We find that the cost per kilo weight loss is 3 times less than the National Diabetes Program or the National Digital Weight Loss Program. And also uptake is 3 times higher, and it's always coming down. So when we've got ARS roles working in one-to-many style approaches like bulk nudge and virtual groups, the cost effectiveness shoots up to the point where it's really, really hard to ignore. And these are really easy things to get started with.
Yeah, no, it's some great ideas there. We might dial down into a bit around that. about some specifics as well. And Alf, what's your thoughts around that? Around this sort of,
Yeah.
it's about systematizing our approach to activation, isn't it? Sure, great if we can have intensive one-to-one stuff, and that really works well. But how can we make this really big scale mainstream?
Yeah, we're onto something here, aren't we? We really are. So digital clearly has got a really big role. I think digital I talk about offloading the clinical conversation. So if you just have a 30-second clinical conversation, and just as you say, Jag, and say, look, you might want to think about this. Shall I signpost you to it? Then the digital can kind of step in and do a lot of the work for us. Digital systems now, there's quite a lot of them out there that we know, not just via the kind of work that you're doing, Jag. There's something called the HOPE program out of Coventry University in the Southwest. 10,000 people have gone through the Digital HOPE program, and there's been massive shifts in activation there. There are other, I won't mention them all, but there are other digital interventions that have been shown specifically to improve activation. So that the kind of one-to-many is absolutely the way forward. I just wanted to say one more thing about group work, and it goes back to Bandura. So, the person who brought out this idea of agency. Bandura had 4 core principles when it comes to supporting people through behaviour change. One of them is do it in groups. So my sense is that our core intervention should, wherever possible, for health coaches, should be group work.
Yeah, it's really interesting, isn't it? And I did some work when I was a GP leader at Sloan Medical Practice, and for me, the key was always around tailoring to, get this concept of activation, that building people's agency is so important, but that actually it's a different modality depending on where you're at. And, if you're perhaps a little bit more highly activated, you will engage with groups and peer support and so on. And that then frees up resource to be more intensive with those people at lower activation, perhaps, where, they may not respond or may not want to join in group work. So I think for me, the real key is to be sophisticated enough you can tailor your approach and tailor your resources to the audience you're working with. I don't know how you've reflected on that.
So that makes complete sense to me. There are clearly some people who don't feel ready to join a group.
Yeah.
That said, there are people at level 1 who, with a little bit of support, do go into groups, and the evidence once they do get into groups is that they seem to do as well as or better than many other people in the group. So I got this phrase, those with most to gain do indeed gain the most if they're exposed to support.
That's brilliant. Yeah, and in fact, of course, that alludes to the fact that we also know from the evidence, don't we, that although it might be harder to sort of build people from a lower level of activation up towards that, those early changes from the lowest level of activation, level 1 to level 2, is where you start to get the biggest return on investment, isn't it? So, really thinking smartly about how you do that activation piece at low levels of activation is just so crucial, isn't it?
Yeah. What I would say, this is not an advert for the Digital HOPE program, but 60% of that 10,000 people in the Southwest that entered the Digital HOPE program were at activation level 1. So, if people at activation level 1 can move into that, just as you've done in your Sloan Medical Centre practice, if you can individually support them when necessary, if they do then move into digital support, my goodness, they can come on leaps and bounds.
Yeah, that's brilliant. And I think it also plays into this value of peer support, which we also the three of us have all talked about, haven't it? That it doesn't always necessarily need to be a professional who's providing the health coaching style support. And, often people with lived experience add an additional value, don't they? You teach them some simple coaching skills and they bring in their life experience and their authenticity with that. It has an additive effect, and maybe, again, I think opens the door to people who might not have wanted to join a group, but will feel less intimidated because it's led by someone who's like them.
I was closely involved with the Expert Patients program for many years, and saw the value of that. I was an Expert Patients program trainer for many years. It was not a perfect program by any means.
Of course, they never are.
But it was peer led, and my goodness, the value of that.
Yeah, absolutely fantastic. And so, Jag, I know you've been doing some really innovative work. I think down in Cornwall, haven't you? You've been doing some. You'd mentioned the symphony work, but you've been doing things across the country, experimenting with different nudge modalities. Tell us a little bit more about sort of where you would go with things. What if you were kind of thinking of, how perhaps someone, trying to think about how they can apply this in the NHS or maybe even in a workplace or at a neighbourhood level? What sort of ideas are going through your head?
The intervention you apply in a complex systems, that often it's a sign that small things done consistently, working together, can generate really complex, wonderful outcomes. But you can't understand why it happened. It's very difficult to. But you've got to focus on the ingredients, the small things everyone can do right now that might build into something complex. So kind of with that in mind, what we've tried to do is say, what could we design that neighborhood health teams, GPs, clinicians, social prescribers can do that's just really easy to implement some of this stuff? So I'll just take you through some work that we've done across a range of pilots in different ICBs, probably about 7 in total, but working probably quite closely with Cornwall over a 2-year period to implement some of this stuff with NAPC, but also with NASP as well. So the pathway looks a little bit like this. We've got multiple different pilots doing it differently, but one common pathway is this. So let's say after a GP appointment, everyone who's had a GP appointment in the last week, we're going to, subject to certain exclusions, we're going to send them a text message. And this might happen in a chronic disease review, quite difficult to fit it into a GP. So you can ask these questions verbally in a diabetes, but with a nurse in diabetes review. That's going really well. We're getting 100% penetration there. Or we send a text message after the contact, everyone in the last week, and we're getting about 30-40% uptake. But it's always rising each time we improve it. And those questions are, how good are you taking care of your health on the 4-point scale? And what's the one thing that you need or we could do to help improve your activation? Some sense of words. So a numbers question and a words question of what they need next. And there's a third question as well, which is something called EQ-VAS, which is how do you feel your health is today? Yeah. And that lets us do the health economics side of things. So it's 3 questions, so dead easy to ask and answer. And what the idea is that if we can now systematically do this for everyone all of the time, and the data lands in EMIS and System 1 in the clinical system. And as kind of you've outlined, Ollie, then you're immediately getting new data about people, their baseline position, and what they need. So for low activation people, for example, who said, I want to move more or I have a housing problem, you've got health coaching, one-to-one health coaching and social prescribing right then and there. You've now, you've addressed that first challenge. You've found people out of the ether and what they need as a function of normal care. Then, of course, if people are high activation and they've said, look, I don't need a program, I just want light touch advice and reminders and goal setting, then you've got large groups or follow-up text messages to send them. And so we're looking at the data and saying, look at these 4 or 5 groups of people and their responses. Let's design a digital pathway of what to recommend or say to them next. The key thing is it's all human, it's all embedded in human relationships. So I just saw my GP this week. So when I receive the text message, I'm thinking of my GP because we refer to it. And similarly, we try to keep it human all the way through. So there are videos of real people, real social prescribers. So my social prescriber, my GP. And at any point, you might offboard into this digital pathway back into one-to-one social prescribing or group work. So it's really digital second, human first, and local human first. That's the main thing. And so all of those tools are near zero cost to try. And just a quick stat, just to link to what you both said, and after you just said about the power of the group and what people need or how small it could be. One of the latest implementations was in Gosport, where we did these questions around weight management. So not general activation, it was more about activation around weight management. And it was so surprising. We found that 64% of people said, I know what I need to do. I just want light touch advice and reminders, or some version of that. Only 7% of people said they wanted typical programmatic weight management. And I just find that astonishing because we've got a system that's catering just for the 7%. And those 7% of people were people who had already been through a weight management course. So there's this kind of weird sense of it creating a dependency, benefits, but also a dependency as well. So there's certainly demand out there for these new techniques, whilst keeping them human. So the final thing to mention are that it's those questions that we've been discussing, the activation questions or versions of it, and some of the others that we've spoken about, they're part of the National Neighbourhood Health Improvement Programme and the National Neighbourhood Health Index. So that's how that programme will be delivered and measured. And also, a recent project I've started to do was working on government guidance for something aligned to the Green Book. The Green Book's how the government measures things for investment. And we're working on a project to have a supplementary bit of guidance that helps non-clinical health coaching style interventions show their value. And they will be using those kinds of questions. So we're getting, great attention from the national kind of reputable bodies that this is the right approach as well. And then, so the final thing to say is that I think ultimately, Alf, it'd be great to get your point of view on this, but I think almost the utopia of this is, how do we scientifically start a social movement? I think that's ultimately our end game here. All these little things hopefully work together to snowball and compound, and then this just becomes normal for us, but we won't know how. But I think the word social movement is the one that I kind of hold in my head the most. Yeah, so that's what we're doing in Cornwall and other places.
Well, I love it, Jack. And there's something about when it feels doable, that often breaks down some of the barriers, isn't it? And Alice, what's your reflections on that then, hearing all those ideas?
So much good stuff there. And I just love the fact that you're grabbing this by the scruff of the neck and doing some fantastic varied work. It's wonderful to hear. A couple of things. One very specific thing comes to mind when you talk about weight management. There was a paper by Trish Greenall and team from Oxford, I think 3 years ago now, demonstrating that people in the more deprived areas around them, I just didn't want to join kind of weight loss programs. They got a suspicion about these formal services. But what they did do was they worked with social prescribing link workers to move into community-based activities. And it made a really big difference. So there's something about deprivation, inequalities at the core of all this, that we're only now starting to demonstrate that sometimes statutory services aren't the right services for people in the more deprived areas of our country. You're demonstrating that. It's absolutely wonderful. I think the other thing that comes to mind is around social movements. And, it's not us that are going to start the social movements. It's all those people in Cornwall and Calderdale. How do we create the conditions where they can not only join up but spread the good news? Yes,
it's so interesting, isn't it? And I like the fact that you're holding the human relationship at the heart of this, Jack. And I think that really is the core thing. I keep reading that. I mean, we've been reading some reports around workplace support and the work well pilots and so on. And actually, it's the human relationship part that is the real catalyst and the enabler. But then we can wrap around all these digital support tools and all these kind of like amplifiers, group work, peer support work. But we need to build it around human relationships.
That's right.
Goodness, I can see we've gone. I could just listen to you guys all day. It's been fantastic, but we probably ought to wrap up. So I'm just wondering if each of you's got any last sort of thoughts around, this principle of activation, around building people's agency. What's your final closing thoughts? Maybe Alf, start with you.
Or shall I come in?
Go on, Alf. You go.
Yeah, I mean, this is such a core and important concept, as Jag has so clearly said. One of my little metaphors is, think of low activation the way you might think as a clinician about a diastolic blood pressure of 120. We can't allow people to walk around the streets with a diastolic blood pressure of 120. We shouldn't allow people at levels of activation, levels 1, 2, walk around the streets without us providing them with tailored support. It's just not right. It's just not right.
Yeah, thanks. That's pretty clear, Alf. And Jag, any last messages from you?
Yes. Thanks, Alf. And then I think for me it would be, I almost wonder what the smallest action that we can do or staff can do that might start this virtuous circle. And for me, I think it'd be to try something that we've discussed and see how it goes. Most people think they've got to put effort into it and get prepared. They need resource and need time. And I think if it feels that way, it feels too hard to make that first step, it's probably a sign that the first step is too big. So make it even smaller. And that's how activation works. The same principles that help us change behavior with people, which is, start small, kind of hook it, have a relationship and compound, they apply to us as professionals as well. So if you can do any of this stuff, make it feel easy, enjoyable. If it doesn't, make it smaller. And maybe the smallest thing you can do is, why don't you try asking one of these questions in front of a person, a patient, a person, or a family member, or sending it on a text message. And even just one patient starts a learning loop, because you'll get something back and that data will give you something to say to somebody different. And then maybe next week it's 5, and maybe that you can group and you can say, oh, look, I've made this change. And that's how the snowball happens. It starts from an actionable first step. So yeah, my recommendation would make it as small as possible so it feels really easy to start when there's no time or energy or money.
Brilliant. Thanks, Jag. Brilliant. And I hope that people listening to this will have sparked something in their mind that they think they can do. But the bottom line is do something, isn't it? It's wonderful collaborating and learning with you. We're learning as we go, aren't we? All the way along. Like you say, we discover, we practice, we put things into action, and it's by doing stuff, I think, that we really learn. So thanks for your inspiration, guys. Pleasure talking to you today.
Absolute pleasure. Thank you.
Thanks both.
Thanks.